Hi everyone, this is Mrs. Nora, and I am here to give you your lecture on spinal cord injuries. So remember, an acute spinal cord injury is a traumatic injury to the spinal cord. It interrupts those nerve impulses that we have between your peripheral and central nervous systems. So what it does is there's an impairment between both your sensory and motor function. Of course, this all depends on the extent and location of damage. It can, result from either minor muscle weakness to complete paralysis. So that will depend on the location of damage and how severe the damage is. So some statistics, about 200,000 people are currently living with spinal cord injuries in the United States. Annually, 15 to 40 new cases per million people, or about 12 to 20,000 new patients are estimated to occur. There's about 1.2 million Americans living with paralysis resulting from spinal cord injury. And then more than half of spinal cord injuries occur in the cervical area, a third in the thoracic, and the remainder occur mostly in the lumbar area. And of course, alcohol has been found to play a major factor in 25% of spinal cord injury causes. And then spinal cord injuries alone roughly cost $40.5 billion annually. Another thing to think about with spinal cord injury patients is that those patients are also often unable to afford health insurance that adequately covers their complex secondary or chronic conditions that are commonly linked with paralysis. So it's a difficult situation for many of these patients, and that they, as soon as they become paraplegic or quadriplegic, they will require assistance for the rest of their life. So a quick warm-up. You've learned multiple pathological conditions that result in mobility issues. So it's important that we're able to assess functionality. We want to be able to identify the problems and be able to implement interventions for your patient. So how can we quantify muscle function? So we can do this by a muscle function grading scale, which we're going to go over in the next slide. But another question I have here for you with the warm-up is identify 5 complications of impaired mobility and at least one intervention for each. So I'm going to go ahead. This is where you would pause and you'd answer this. So 5 complications of impaired mobility and at least one intervention for each. And then once you hit the play button again, you'll hear my answers. So 5 complications. One of them is pulmonary, obviously, which, complications of impaired mobility with pulmonary can be atelectasis and pneumonia. So what can we do for that? We can do, if they're able to, do coughing and turning, try to have them do some deep breathing, and then we can do percussion therapy if we need to as well. Circulatory. So that's another issue, another area that complications can arise. So you think about venous stasis, edema, clots, orthostatic hypotension. So many of those can be, interventions are based off of immobility and then monitoring vital signs and any sort of complications after the injury, which will go into some of the complications you can get after spinal cord injuries. Skin. So pressure ulcers is a huge complication of spinal cord injuries and impaired mobility. So, what we can do to prevent pressure ulcers is frequent turning, good skin care, keeping the skin clean and dry. Very, very important. And actually, a lot of patients, it's sort of, once they develop that pressure sore, especially in like the sacrum, it's almost like there's no way of going back. It just keeps progressing. Uh, Another complication is GI. So think gastrointestinal complications, so constipation, incontinence, and impaired mobility. It's just you're not able to move your bowels as frequently as you could be when you're up and active and moving around. And then most of these patients will have incontinence. They're unable to control their bowel or bladder, or they may even have neurogenic bowel and bladder. So that also causes issues. And then urinary. So urinary is another complication that we can get from impaired or urinary complications would include urinary retention, incontinence, of course, infection. Some of these patients require chronic Foley's or intermittent self-catheterization. So there's always that risk of infection. And then, with incontinence, you have to worry about skin integrity. And then retention, you have to worry about all the neurogenic issues that you can have from that. And then another complication that we think about with impaired mobility is, musculoskeletal things. So osteoporosis, fractures, contractures, and then even hypercalcemia. So interventions for that, we want to make sure that, we try to prevent contractures with lots of range of motion exercises, and then we'll make sure to do proper positioning and, especially like, for example, we have a patient who's having a contracture in their hand. We'll put in some rolled up washcloths in their hand to prevent, the fingernails from digging into their skin, to help keep that from contracting even more. So there's things that we can do as a nurse when you see patients who have contractures, and then that's just a list of some of the complications that you can have associated to impaired mobility and related to spinal cord injury patients. And then we're going to go into that a little bit more. So I talked about this previously, the muscle relaxation scale. So if you go to page 769 in your book on table 35.12 on page 769, there's a guide to help you gauge your patient's motor strength. So it's known as the muscle relaxation or muscle scale. The scale grades muscle power and strength on a scale of 0 to 5, and you can see that MRC scale up there. You will need to remember this, so please try to study this as much as you can. The 0 to 5 scale, it's in relation to the maximum expected for that muscle. So you can see there's different in regards to range of motion and how they can move based off of the amount of gravity applied. So it's a more reliable and accurate scale when we're looking at clinical assessment in weak muscles. So a 0 is there's no muscle contraction, they're completely paralyzed, there's no movement. An MRC scale of 1 means that they have severe weakness and muscle contraction only. A 2 is severe weakness, they have full range of motion but without any to gravity or to any resistance. And then a 3 is that they have moderate weakness, they have full range of motion against gravity, but not to any resistance applied. And then a 4 is slight weakness, they have full range of motion against gravity and some resistance. And then 5 is strong, full range of motion against gravity, and they are able to do full resistance. So that's something that you might see in practice, and especially in your rehabilitation, your inpatient rehabilitation units where you take a lot of neuro patients, stroke, spinal cord injuries, those things. This is used pretty often, and especially by physical therapy and occupational therapy. So a quick overview. So spinal cord injuries are, of course, secondary to a trauma. The spinal cord's 18 inches long. It has nerves within the spinal cord that carry messages from the brain to the spinal nerves and back. So injuries resulting from a concussion, a contusion, compression, tearing, laceration, transection, or ischemia of the spinal cord can all cause issues with the transmission of messages within these nerves from the brain to the spinal nerves in the back. The vertebrae are there. They're objects that can also be forced against the spinal cord. I mean, they serve a purpose, but they also can cause damage as well. Preventing those messages between the brain and the body. And so what can happen is if the vertebrae, moves and compresses the spinal cord, then again, you have this sort of hindering with that messaging with the nerves and transmission to the brain and body, between the brain and body. So the result is sensory information that goes to the body, to the brain, all that motor information from the brain to the body is impaired or even absent. So that communication is either impaired or non-existent. So what are some causes and risk factors? Usually younger age, 16 to 30 is about average. And, younger, they're more free-spirited and are more likely to take risks, the male gender especially, and then risky behavior, so diving into a shallow pool, all these ATV sports, motorcycles, anything that they might do without using the proper safety equipment and gear, and then motor vehicle crashes, alcohol, alcohol use too. Think about the age 16 to, or actually 21 to 30, I should say. I'm sure that underage drinking does happen too, but alcohol is a factor as well in that age group. And then you think about older adults, they're actually more likely too because they fall. And then they also have that risk factor for having osteoporosis. So here are some examples of mechanisms or causes for spinal cord injury. So you can see how different impacts and different ways that how the injuries can occur. So whether it's force from like diving or force from motor vehicle accident hitting the windshield, force going down or force bending. So you can see how it would affect the injuries, how they would be different. So prevention, what are some things that we can do to prevent spinal cord injuries? A lot of it's about, safety. No drugs and alcohol when driving, wearing the seat belt, child safety seats and booster seats is important. Avoid diving if water is too shallow, never in above ground pools. Wear appropriate gear for sports and helmets if bicycling, skateboarding, ice skating. I know, I have a young boy, he's 11, and it's sometimes difficult to get him to wear that safety gear, but he's at an age too where it's like you need to teach them why they're going to have to wear it and the importance of it. Wear your helmet. This is why you have to wear a helmet. And they're just at a higher risk. And he's a boy, young, and, wants to do things freely. Fall prevention strategies, especially for elderly. So we'll definitely do some good fall risk assessments. And then we'll do, fall prevention and interventions to prevent anything from happening. So, a lot of times we'll educate our elderly on making sure that you have non-skid shoes on, no throw rugs, have the light on when you're up walking around at night, those kinds of things. And then, if possible, try to have people avoid high areas of crime and violence. And I think that's especially important for spinal cord injuries that are caused by like stabbings, gang violence, and gunshot wounds. So the pathophysiology, you can kind of see in this image here, different types of causes of spinal cord injuries and, what happens to our body. So we have this initial trauma episode and we have an injury that occurs. So this trauma causes bruising, bleeding, edema, and tearing of the spinal cord. So what this does is it creates decreased blood flow, decreased oxygen, and decreased nutrient supply, causing these neurons to die. Now, edema causes direct pressure on the nerves. You think about all that swelling from the edema. You also have inflammation due to immune cells in this space, stimulating formation of scars. So with this picture with John Doe, you can see the fractures of T5, T6, and T7, with T6 being a burst fracture, all those shards, and then the injury to the spinal cord caused by the burst fracture. You see how the spinal cord is sort of indented there. That's from that burst fracture. So what are some clinical manifestations? A lot of it is dependent upon the level of injury. So it really determines what parts of the body are affected. And then we'll go into further depth on the next slide as to what you might see at each level, whether it's cervical, thoracic, lumbar, or sacral. It's affecting those nerves. So typically some emergency signs and symptoms that you might see with spinal cord injury. So these are signs and symptoms that you really want to act upon as fast as you can. And these signs and symptoms tell us that it's probably not good. So this spinal cord injury is probably paralysis, quadriplegia. It's not it's at a level of injury that's not good, which is like cervical area and below. If you have an injury in the cervical area. And we'll go into that further. So some signs and symptoms that are cause for big concern are extreme pain. If there's pressure in the neck or back, they'll have weakness, but they describe it as paralysis or aplesia. They have a lack of sensation or pins and needles, a paresthesia. They might have the loss of bladder and bowel control, especially if it's a cervical injury. They might have impaired breathing. You might notice an oddly positioned neck or back, and then they also might have muscle spasms. So some things to look out for if you're, concerned that somebody has a spinal cord injury. And this is especially important if, say, you're the first one to arrive to a trauma, or you notice somebody diving in the pool and something happens, then you can kind of look for these signs and symptoms to see if it's a spinal cord injury. So here's the table that shows you an image of a comparison of a normal. So table 37.6, table 37.6 on page 820 shows you an image of a comparison of a normal and herniated disc. So it's something just to look at to get a clearer image of what it looks like with, another cause of nerve damage. And then figure 37.12 on page 832 is similar to the above image, and it shows the spinal cord injury level. So clinical manifestation of nerve injuries, your most concerning injuries are going to be the cervical ones, and anything from about C5 and above. So C1 to C4 injuries, you're going to have quadriplegia, and then you're going to have loss of spontaneous respiratory function. Now, C4 and C5, you might still have issues with your respiratory function. You'll definitely be quadriplegia. And you'll also have possible phrenic nerve involvement. And then it's good to know this information for general and NCLEX, but this is something that you should study. So C5, C6 injuries, you'll have quadriplegia, definitely with gross arm movements, phrenic nerves intact. C6, C7 is quadriplegia with biceps intact. They'll have diaphragmatic breathing. C7, C8, you'll still have quadriplegia with triceps, biceps, and wrist extension intact, some function of the hand muscles. And now we get into the thoracic region. So T1 to T5 is paraplegic. So pretty much everything in your cervical region is going to be quadriplegia. And then anything below that is going to be paraplegia or less, depending on, especially if it's a sacral injury. So T1 to T5, paraplegia with trunk and leg involvement and normal arm and hand movement. So those you'll definitely see sort of upper body is okay, lower body completely flaccid. T6 to T12 injury, paraplegia with the fair ability to control balance and trunk, little or no voluntary bowel or bladder control. And then below an L1 injury is like pelvic nerves. It's variable. It's going to vary whether or not they'll have motor and sensory loss in the lower extremities. It depends on the person, and it'll depend on whether or not they'll have a reflexive bowel and bladder. So another table to look at is 37.6 on page 832. It's a great resource for you to review and study because it lists all of the injury levels I just reviewed with you and resultant functional loss. So really the most important thing to remember is that the cervical injuries above C4 can result in that inability to breathe, and of course quadriplegia. Thoracic injuries often result in paraplegia and can include poor trunk control, and lumbar and sacral injuries result in decreasing control of legs, and bowel and bladder function and sexual function too can be variable depending on each person and the injury. And just so you guys know, with and it's an uncomfortable topic, but sexual function. So a lot of these patients, especially women, they're still able to carry pregnancies to term. They are still able to do those things, but they just can't feel it. The other thing is too that they, they, I guess, can pretty much, if their partner or whoever they're with, they can still have a relationship. It's just that, again, they won't have any feeling there, but all of the functions are still in place. Okay. So classification. Spinal cord injuries are divided into two classifications, either complete or incomplete injuries. So complete, there's total loss of all sensory and motor function below the level of injury. Damage is irreversible. Incomplete, you'll have partial loss of sensory and motor function, and below that level of injury. They may have sensation, but not really any motor or any movement with no sensation. So incomplete, you have partial loss of sensory and motor function below the level of injury. That essentially means it's incomplete. They may have sensation, but no motor or movement without sensation. So it just varies. Also, there are 4 types of incomplete injuries. See figure 37.11 on page 831. This is a good figure to kind of help you study for those 4 types of incomplete injuries. So central cord syndrome is the most common incomplete injury. There will be hyperextension. It's a hyperextension injury with central cord swelling. There's an anterior cord syndrome where there's acute anterior compression from bony fragments or acute disc herniations. You can have posterior cord syndrome, which can be from acute compression, or the Brown-Séquard syndrome, which just means there's like a hemisection of the spinal cord affected, resulting usually from a penetrating injury like a gunshot or a knife wound. And it could also present from primary ischemia, infection, or even a hemorrhagic event. So here's a quick reference for you to help with reviewing the spine, the number of vertebrae, and what areas of the spine controls nerves in the body. Those are all listed above in each section. Cervical controls the diaphragm, the chest wall muscles, the arms and shoulders. The thoracic region controls your upper body and GI function. The lumbar and sacral region controls the lower body, including the bowel and bladder. All right, so emergency care of these patients. So typically when a patient presents to the ED, or if they're admitted with head trauma, unconsciousness, a penetrating injury near the spine, having had a fall, or have been in a motor vehicle crash, patients need to be ruled out first for any spinal cord injury due to several factors. So a lot of times in the ED, and those of you that work in the ED maybe can share some experiences in class, but we definitely keep them in alignment, and we stabilize the spine with immobilization until any sort of injury, a spinal cord injury, is ruled out. So the reason we do that is because any significant movement of the spine when there's an injury can result in further damage. We don't want further damage to happen. We want to do a very thorough physical and neurological exam, including reflexes. Usually the physician will do that. And then Most likely the doctor will order an x-ray of the spine, a CT scan, or an MRI, because we want to find the location and extent of damage to reveal what localized problems there are. And then the following are managed as a spinal cord injury until ruled out. So head trauma, when they come in unconscious, any sort of penetrating injuries near the spine, if they've fallen, and then a motor vehicle crash. So continuing on with emergency care, of course we want to maintain the airway. That's one of the priorities that we need to worry about. It's sort of an immediate thing that we will take care of. Most patients en route to the ED that come via an ambulance or EMS are immobilized with a neck collar, head tape, backboard. They might even have sandbags or blankets on the sides of the patients to prevent them from rolling. A third of these patients will require intubation, so there is a good chance that patients will arrive already intubated. We want to make sure that we maintain spinal immobilization and stabilize them to prevent further damage, especially if it's an unstable spinal column. We just need to make sure that we don't cause any further damage until we identify the level of injury. During the initial stages of injury, treatment is focused on maintaining the airway, making sure that the patient's getting adequate oxygenation and that they're breathing or we're breathing for them. We want to prevent spinal shock, and then we want to restore and maintain blood pressure. Again, prevent any further cord damage, maintain spinal immobilization, and avoid possible complications that could occur if we did not keep spinal stability. So expect to monitor vital signs very closely with these types of patients, especially for signs of spinal shock. So this is a image on how to do the log roll, which is a common technique that's used throughout, I'd say, the ED and out in the field. It's just a way that we can move patients with a suspected spinal cord injury or with a spinal cord injury safely so that we don't prevent any further damage. And it's a group effort. Everybody does it together. Each person is assigned to a section of the patient. One person holds the head. The other three have sections of the body, and then they all count down and roll the patient at the same time. So some diagnostic tests we'll do is, time is really important when it comes to patients' outcomes for this, especially with identifying the spinal cord injury and treatment. So we'll almost always do a CT, which is the quickest, or an MRI. It's just that they're more sensitive with identifying the exact location of the fracture or soft tissue injury and damage. For CT, if contrast is used, consider this nephrotoxic. So we want to inquire about metformin use, find out if the patient's using that, and if they are, we'll hold it for 48 hours before or after contrast. ABGs, we'll do ABGs. We want to get an idea of their respiratory status, their insufficiencies. Are they in respiratory failure? Can they breathe on their own? Labs will show us if there's a hemorrhage. We'll monitor H&H. And then there's multiple ways too that physicians can test spinal cord injuries. There's one that's called the ASIA exam. You might see some physicians do this in the ED. It's ASIA stands for American Spinal Injury Association, and it's exam that's a standard physical exam to help determine which parts of the body are working normally and which parts are affected by the spinal cord injury. So this is just for your information too. It's a motor exam, sensory exam, and then at the very end too, they'll do an anal muscle exam. All right, so treatment for spinal cord injuries. Again, after the airway is established and we maintained oxygenation, then, especially if it's a C4 injury or above, they're going to require mechanical ventilation. T6 chest muscles, so thoracic T6 section chest muscles, T12 abdominal muscle, difficulty with coughing, it just depends. So, depending on the level of injury and if they're having mechanical ventilation or not, it's going to vary on, how much involvement of breathing and chest muscles and diaphragm and even coughing that they're able to do. It's something that we have to consider when it comes to treatment. So we'll monitor spinal shock. We'll restore and maintain the blood pressure. We'll maintain spinal immobilization, prevent that further cord damage, and then avoid complications of immobility. So we're going to turn frequently, do some good skin care. Now, we can do surgery, so if there's definite evidence of spinal cord compression, progressive deficits, if there's a compound vertebral fracture, penetrating spinal cord wound, or bony fragments in the spinal canal, we can do surgery, and that's performed early on to help with decompression, and fusion can also be done to stabilize the spinal column. So decompression is where surgeons work on removing the debris, and then spinal stabilization or realignment is where they would place rods and screws. So in here you see they have spine realignment. This is a good image that shows you what are some treatments and things that can be done to help with traction and stabilization. So page 833 discusses immobilization and stabilization of spinal cord injuries. It's, again, something that you should read into. So traction and stabilization. So this can be done to help create spine realignment if there's not presence of any major cord involvement. Really what this does, it's a halo device, and it looks very barbaric, but it's used to maintain immobilization for specific types of cervical fractures, and they can wear these for a long time. There's titanium screws that are screwed into the skull bone. It's attached to this halo traction device. So it's this metal ring that goes around the forehead area, around the head, and then it's resting on the shoulders. It's attached to essentially a halo traction device. Weights can also be added to the head of the bed over a pulley system. So if you can see, there's the Gardner-Wells tongs. That one is one that they use the titanium screws screwed into the skull, and then they attach this halo traction device. And then you see how they can add the weights to it, and they provide weights so that it's to the point of stabilizing the patient and stabilizing that spinal cord, and depending on where the injury is. So they'll add weights, and they'll add them slowly, and they'll take x-rays at the same time in between adding each weight to make sure that they've developed or that they've added the proper amount of traction so that spinal alignment is achieved. So it's very interesting, and again, it does seem very barbaric. The other one I was talking about, the rest on the shoulders, is another halo device. So you have halo traction, which is the image down on the left there with the Gardner-Wells tongs. And then the other one is the halo device that, again, it has pins that are screwed into the skull, and it keeps the neck in alignment so that the patient cannot move the head or neck or turn. So for both of these, they do require good nursing care for the pins that are inserted into the skull. So we do what's called pin site care, and we frequently assess them for signs of infection. bleeding or CSF leakage, cerebral spinal fluid leakage. We want to maintain traction. Whenever we're moving these patients, repositioning them will maintain log roll, especially the ones with the Gardner-Wells tongs intact, the ones with the halo device. I've seen them sitting up in chairs. So they're a little bit more mobile when it comes to movements with that the halo ring. So one other safety alert here that I'm going to talk about is the pin site care. And so with this, pin site loosening is one of the most common complications of that halo brace. About 60% of patients can have that pin site loosening. Look at page 835, the safety alert, and read that, please. So redness, swelling, drainage, site pain, or areas where the skin gets pulled away from the site can happen. If no infection is present, then the provider can just tighten the pins. But if an infection is present, then there's other things they need to do. So the pins, the reason for them being tight is to maintain immobilization. We don't want the patient moving. We want everything to be aligned. Patients can complain of neck pain, or that's so one thing that can indicate that the pin site is loose. Pin sites are loosening. Is that the patient will complain of neck pain, or that their halo vest there doesn't fit right or doesn't feel the same. They might notice the ability to move their neck, to move their head, which is not good. If you ever notice that this is loose, we can immediately apply a hard C collar and then prepare them for x-ray. And then, of course, we'll also do detailed marrow checks to make sure that the patient hasn't had any new deficits or worsening deficits. So some halo and brace traction complications. We talked about pin infections a little bit in the last slide. So we do provide pin site care. We prevent infection by cleaning the pin sites. It's just normal saline. We soak it in a cotton applicator. We do one cotton applicator soaked in normal saline per pin. You go around the site and you do that once a shift. If crusting is noted, you can always wrap a gauze soaked in normal saline and then leave it on that pin site for 15 minutes and then try to remove after removing the gauze, and you clean it with a cotton tipped applicator to gently remove the crusting. Sometimes patients can get pressure ulcers underneath that vest. So we usually put sheepskin or some other type of padding between the shoulder blades and then that halo device. So underneath that vest, there's something that's protecting the skin there. You want to do good skin care. You want to make sure that there's a good proper fit. And then, you want to just do frequent checks. So part of that every 2-hour assessment, or, whenever you're doing your skin assessment, is you're going to take a peek underneath that vest and look at the skin by the shoulders. And then too, if they're having swallowing difficulties, then we really need to consult our provider. We might need to refit the vest or figure out a way to refit things. And then we might need to call speech therapy. You think about swallowing and not being able to move your head or neck. There is that potential for swallowing difficulties. So spinal shock, we've talked about this a little bit here and there, but let's talk about what it is. So it's a complication of spinal cord injuries, and it typically occurs immediately after the injury. It can last from about 24 hours to even 1 to 6 weeks. So typically you can see it immediately, but it can happen, within several days after that injury. So the return of reflexes below the level of the injury indicates the conclusion of spinal shock in your patient. So during spinal shock, the brain is unable to transmit signals to muscles and organs, resulting in loss of sensation, movement, and other body functions. So that's why I say the return of reflexes below the level of the injury indicates that the conclusion is spinal shock is done, because spinal shock causes loss of sensation, movement, and other body functions. So it'll be a complete but temporary loss of most spinal reflexes. They will have a loss of sensory, motor, autonomic activity below the level of the injury. Low blood pressure occurs due to sympathetic tone loss as a possible complication. They'll have flaccid paralysis of all muscles. They'll have absence of deep tendon reflexes, impaired proprioception, decreased visceral and somatic sensations. They'll have urinary and fecal retention, absence of sweating. They'll develop a paralytic ileus, and um, spinal shock is just, it's not, it's kind of a scary thing for the patients. I'll say that too. And then for us as well. Another thing you can check, so there's something called the bulbocavernosus reflex. It's listed there on the slide, so you know how to spell it. It's not mentioned in the book, but it's a test. It's just for your information. So it's a test that involves monitoring the internal external anal sphincter contraction in response to squeezing the glans penis or clitoris. So really what this does is you tug on, most of these patients will have an indwelling Foley catheter. And so when you tug on the indwelling Foley catheter, it's something that can help to determine if spinal shock is still present. So I don't have, so this anal sphincter contraction responds, and I guess you would monitor to see if there's this contraction when you're pulling on that, tugging the indwelling Foley catheter. It's not something that we would regularly do. It's probably more physician related, but I'd say the most predictable sign of spinal shock being over with is that return of reflexes below the level of injury. So we've heard of neurogenic shock. We just learned that. So what's the difference between spinal shock and neurogenic shock? So spinal shock is shock of the spinal cord. It's like a concussion of the spinal cord, and it's not vascular in nature. However, because of the damage, the patient will have bradycardia, so low heart rate, hypotension, low blood pressure, and the severity depends on the level of injury. As reflexes return slowly, you might see some spasticity with the muscles. Real thing is, really with these patients, we need to inform them of what spinal shock is and what to expect, because it can be really scary. Neurogenic is a distributive type of shock, so it's vasodilation. So you have that sudden loss of the sympathetic nervous system signals. It requires colloids and atropine, particularly occurs with injuries at T6 or higher. So that is the difference there. And I think this table here, or chart, I should say, is good about sort of differentiating between the two. So here with spinal shock, it's an immediate but temporary loss of total power, sensation, and reflexes below that level of injury. And then neurogenic shock is that sympathetic nervous system signal and loss of that signal. They both tend to have hypotension and bradycardia. That bulbocavernous reflex is absent with spinal shock, and it's variable with neurogenic. Flaccid paralysis too with spinal shock. And then the timing, both can actually be around the same time. So 48 to 72 hours immediately after that injury. And then that talks about the mechanism there too. So, autonomic dysreflexia is something we have to watch out for. If you look on page 835, table 37.8 details nursing interventions for the treatment of the patient with autonomic dysreflexia. So we know it is a syndrome of massive imbalanced reflex sympathetic discharge, and it occurs in about 80% of patients with spinal cord injuries above the T5, T6 level. So it's very, very common. This is something that we really want to teach our patients about. It most often occurs after the first year of injury. So after the first year of injury, but can occur at any time after spinal shock subsides. It's triggered by a sustained stimuli at T5, T6, or below. And we'll talk about what that stimuli could be. So the most frequent cause of autonomic dysreflexia is actually a full bladder. And the second is a full bowel. So crazy enough that a full bladder and full bowel can cause this type of a systemic reaction on this patient. Other causes include tight clothing, gastrointestinal disturbances, like an ileus, DVT, pressure ulcer, bladder or kidney infection even. Temperature extremes can even be a fan blowing on a patient. Shoes, too tight of shoes, if they're lying or sitting on a hard object, or even a minor injury. Clinical manifestations, they'll have a severe headache. It's kind of the telltale sign, a headache, hypertension, and high blood pressure, bradycardia, so low heart rate, or tachycardia, really fast heart rate. And that's the thing with this, is that they can have both. So they could have bradycardia or tachycardia. A lot of it's going to be, you're going to look at that hypertension and see, wow, they've got super high blood pressures, they have a headache, and they're going to be diaphoretic, they'll be sweaty, and they'll have flushing of the skin above the level of the injury, and they'll be pallor or pale skin below the injury level. So those are some common clinical manifestations of autonomic dysreflexia. Let's do a connection check here. So which interventions are indicated to treat the loss of vasomotor tone, neurogenic shock, in the patient with an acute spinal cord injury? Select all that apply. So go ahead and pause, answer the question, and then as soon as you hit play, I'll be talking again and give you the answers. So the answer for this question is A, D, and E. So loss of vasomotor tone causes that blood to pool in the vessel. You'll get low blood pressure. IV fluids, vasopressors, inotropes are often used to give that adequate fluid resuscitation and then try to get the blood pressure back up and increase the cardiac output. Okay. Pharmacology. So what are some drugs we're going to use? Corticosteroids. So this is kind of more controversial, and the more I've been reading into corticosteroids, it seems like they're using them less and less. But just so you know, you might see this in practice every so often, and it might still be in practice, but high-dose methylprednisolone, so remember that's a corticosteroid, or any other type of corticosteroid. It's supposed to help reduce the inflammation, but they're saying now that there's not a really good, strong medical evidence saying that there's any benefits. So, you might see it still. There's also harmful side effects of any type of steroid. So you have your hypoglycemia and immunosuppression, but it's just so you know that corticosteroids were actually like the, I guess, top treatment pharmacology for these patients at one point. Antispasmodics, such as baclofen, dantrolene, baclofen I probably see more often. So they're typically given to patients who have painful spasms and decreased mobility. However, looking at current research, there was a study that hypothesized that antispasmodic medications may actually impede recovery from an acute spinal cord injury by decreasing neural activity. But just so you know, you might see patients with baclofen to kind of help some of the painful muscle spasms they'll get. Analgesics, they might have pain above the level of injury due to damage to the spinal cord or nerve roots. So we'll do opioids, NSAIDs, whatever the doctor orders. They may need vasopressors or vasoactive medications. Look at page 788, table 37.7. So loss of the vasomotor tone causes blood to pool in vessels and results in low blood pressures. IV fluids and vasopressors and inotropes are often used to provide adequate fluid resuscitation and increased tone, as well as help with that cardiac output and increased cardiac output. We talked about these before. Norepinephrine, dopamine, dobutamine can all help with maintaining hemodynamics of the spinal cord injury patient. Of course, we'll do anticoagulants. All those fluid shifts after the spinal cord injury, they can be at risk for developing PEs. We also have to worry about immobility and monitoring for DVTs. So they're usually on Lovenox injections or some heparin, some sort of blood thinner. And then stool softeners. A lot of times this can kind of get overlooked with these patients, but they do need a good bowel regimen to prevent that causing autonomic dysreflexia. So we want to make sure that they regularly have bowel movements and that they're being tracked, that somebody is paying attention to how often they've had bowel movements. Connection check. So which action is the highest priority in the patient who presents with autonomic dysreflexia? Prepare for intubation, initiate vasopressors, remove the stimulus, or place a temporary pacemaker. Go ahead and pause. Your answer is C. So autonomic dysreflexia develops, we have that strong sensory input. It can be caused from a number of things: distended bladder, temperature changes, infection, full rectum. So we want to remove that stimulus. And once we remove the stimulus, they rapidly improve. All right, nursing management of these patients. So, of course, we're going to do lots of assessments. We'll do some very thorough neuro assessments, respiratory. We're just making sure that we're assessing for hypoventilation, especially if their levels of injury are in that cervical region. With T-level injuries too, we might look for how well are they breathing, how well are they breathing, how well are they able to clear secretions, do they need assistance with coughing, those kinds of things too. Also, especially with those T-level injuries, you might have a loss of intercostal muscle function, so then they have a decrease in that tidal volume, and that could also lead to hypoventilation. So we're looking at all these different things when we're assessing lung sound. We'll watch vital signs, looking for spinal shock, hypotension. We're going to watch for neurogenic shock and autonomic dysreflexia a little later on. And then motor function, sensory levels, we're going to look to see what the deficits are. Are they increasing or decreasing over time? And then for pain, any pain above the level of injury we'll treat. Intake and output is especially important. We want them to have good nutrition, make sure that they have good urine output, they're urinating, they're not having urinary retention, and same thing that they're having consistent bowel movements. If they have any surgical pins or surgical sites, we're going to monitor those, signs and symptoms of infection. Bowel sounds too. In general, these patients can have decreased perfusion to the GI tract. So this can lead to decreased gastrointestinal motility. So what happens when we have decreased GI motility? There's always that risk of paralytic ileus with these patients. So another reason to monitor bowel movements and bowel sounds. And then skin too, we're going to do what we can to prevent skin breakdown, so good incontinent care, and then turning and repositioning often. Um, Nursing management actions, so we're going to immobilize and stabilize. Those are priorities. We'll do pin site care. If they're having a hard time with respirations and clearing secretions, we'll do suctioning. We'll do oxygenation. We'll try to help them with effective coughing. So they might, require us to do percussion therapy or to help them with clearing those secretions. We'll do passive range of motion to help with preventing contractures, that loss of muscle tone. We'll try to strengthen the unaffected muscles as best we can. And then with there being decreased perfusion to the GI tract, and decreased GI motility. Of course, we worry about paralytic ileus. There's also decreased renal perfusion, so to worry about the kidneys. They might have decreased urine output for that reason. So another reason why we want to monitor intake and output numbers closely, and then monitor bowel movements. And skincare repositioning we talked about. So, keeping the skin clean and dry, TVT prophylaxis, and a lot of what we do for these patients encompasses pulmonary care, suctioning, assisting with cough, turning the patients, preventing pressure ulcers, trying to prevent DVTs with prophylaxis, bowel and bladder training and monitoring, management of nutrition, and monitoring vital signs and hemodynamics. Okay. What are we going to do for teaching for these patients? So definitely we want to teach them about autonomic dysreflexia. We're going to teach them the signs and symptoms. Teach that to their patients and their family members, because a lot of these patients will require 24-hour care. And so whoever's going to be taking care of them really needs to be involved with everything that we do when we care for these patients. We want to teach them about autonomic dysreflexia, the signs and symptoms, what they could do to remove the cause of it, and let them know it's potentially a life-threatening emergency. If they are going to go home with a halo device in, we need to teach them how to do skin care and pin care. We want to prevent skin breakdown, the importance of changing positions, site and pin care standards, and they can have these in for a long time. Whether they go home or inpatient rehab, respiratory care. So, especially depending on the level of injury, if they're really not able to clear their secretions on their own, then we need to teach the family members how to do that, how to help and assist the patient with clearing secretions. And they may even go home with medical devices that will do that. There are home percussion devices that they can use to help clear secretions. And we want families to be able to recognize the any type of respiratory distress or respiratory complications. And then too, we want to make sure that they're aware of the importance of monitoring intake, output. Are they urinating? How much? Are they having bowel movements daily? We want to make sure that if they have a bowel regimen that's prescribed by the physician, they know how to do it and they know what to do in case, say, they don't have a bowel movement or they're not urinating on their own. So really, for when we're evaluating the outcomes with these patients, really the focus is just on getting the patient through that most unstable phase of spinal cord injury, that first 48 to 72 hours, and then airway management, cardiopulmonary support. We want to maximize spinal cord perfusion and oxygenation, delivery of oxygen, pain relief, and then we have to prevent any further injuries or complications. And the acute phase really is all about stabilizing the patient. The chronic phase is long-term rehabilitation of the patient. They'll require intense inpatient rehab therapy. I'd say almost all of them are sent to a facility, inpatient rehab, that hopefully specializes in spinal trauma. And then a lot of emotional support, because it's going to be a chronic phase for the rest of their life. So make sure you review the, that's not on Moodle, that spinal cord injury algorithm. There's also review and complete the other complications activity. There's a Google Drive link that's going to be on this next slide that I'd like you to complete the chapter review questions. And then if there's any practice quizzes on Canvas, do those. I want to say that spinal cord injury did not have anything with Davis Advantage available, so there isn't a Davis Edge quiz. And then we will go over the Jeopardy game for spinal cord injury and increased intracranial pressure in class. So prepare for that. When I see you next, let's go over some of these questions too. So here's the link for the Google Drive article. So try to complete the tables regarding complications for each body system, and then interventions for prevention or after occurrence. And then you can always refer to your nursing intervention section of your textbook, your nurse's pocket guide. And then let's do some questions. So patients admitted with the C5 spinal cord injury, on admission, what is the highest nursing priority intervention? Assessing motor and sensory function, maintaining spinal cord precautions, assessing vital signs for symptoms of shock, or preparing for an MRI scan. Go ahead and pause and answer. So the answer is B. The highest priority intervention is going to be maintaining that spinal cord precaution. Want to immobilize it and prevent further injury. A 30-year-old man with a C-spine injury is placed in a halo vest for which of the following reasons? To decrease infection, to prevent spinal shock, to immobilize the spine, or to hasten wound healing. So go ahead and pause. Okay, answer C. So that halo vest is used to immobilize the spine. You have the pins that go into the skull, and those are placed in there to lock the head in place and maintain immobility, so we're not causing any further damage until that spine can be fused or until the spine heals. So a 24-year-old with a history of a fall last year and resultant T1 injury is admitted for severe headache and nasal congestion. On assessment, vital signs reveal bradycardia and hypertension. The nurse determines which of the following is the probable cause of his symptoms: absence of deep tendon reflexes, distended bladder, respiratory distress, or overexertion. Go ahead and pause. The answer is B. This is a classic autonomic dysreflexia. So one of the causes is a distended bladder. The nurse is assigned to care for 4 patients. In planning their rounds, in which order would the nurse assess the patients? A postoperative thoracic spinal fusion patient requesting frequent pain medication, a newly diagnosed ALS patient who has had difficulty breathing during the previous shift, a patient with an established cervical spinal cord injury whose last reported BP was 88/40, or a patient with MS who is reporting new onset blurred vision and weakness of her left leg. So go ahead and pause, figure out the order that you would see these patients in. All right, so answers are B, C, D, and then A. So airway is always going to be the high priority. The nurse would want to assess this patient who's been having difficulty breathing. And then C is circulation, which is the next priority. So that patient, would assess the patient C next. And, it could be the patient's normal blood pressure, but we need to evaluate it. And then D, it's, a thorough assessment of new deficits needs to be made, and probably, we'll notify the physician of them. And then A, pain management would be sort of an intermediate priority. All right, and that's all. If you have questions, go ahead and please contact me. Thank you.